Excellent, excellent. Okay, well, good afternoon. Thank you very much for joining our VSY symposium. We're excited to present some of our latest findings and to give an overview of the new technology that we have to talk about today. Many of us, of course, are in the pursuit of presbyopic correction, and we hope to share with you some of the experiences we have and some of the theory behind the Acriva Trinova Pro, which you'll hear about more today. My name is Ike Ahmed. I'm from Canada, United States, and it's my honor to help to moderate this session. We have a great line of speakers, which I'll introduce shortly. And what I hope to do is just share with some overview, a little bit of perspective about why we're here and what we're speaking about. So I can get my slides here as well. So, you know, it's quite nice. We're here in Milano. We're here in Italy. Italy has been, you know, the bastion of science and innovation for so many centuries over the last, you know, many years. And in the spirit of innovation, in the spirit of scientific discovery, I wanted to talk about, at the beginning here, two very important scientists. And you probably know of them already, and that's Fibonacci and Grimaldi. And both of these great scientists, you know, in their age and time, looked at things a little bit differently. They challenged the norm, they challenged, you know, the way things were looked at, and they both have important principles that apply to ophthalmology. Of course, we know the Fibonacci principle. We know, of course, the sequencing, where the sequence shows that each number, as you see here, is the sum of the two preceding numbers. This is quite a fascinating, of course, phenomena that Fibonacci series described. And the ratio is the series approximates to 5, which is basically the golden ratio. Now, you'll hear about why the golden ratio is relevant here, and I think VSY has done a really nice job to kind of discuss and talk about why the technology kind of is about the golden ratio. Now, what is the golden ratio? How many heard about the golden ratio? Because the golden ratio has been used by many artists, it's seen in nature, and it really kind of blends between science and harmony and visualization. So here's for an example. You can see, of course, the example from the Sistine Chapel here, from Michelangelo's paintings. And you can see the proportionality here obeys the golden ratio. And you can see the hands touching, of course, in this very beautiful picture that we've seen over the decades and over the years. And basically, it's the size of the height and the width and the proportions here that, you know, the true artistic talent can appreciate. I just think it's a beautiful picture, but when you look at the ratios of this, it now sort of shows why we have a masterpiece that really describes the golden ratio. The golden ratio also is something that we see in nature. We see it with animals. We see this with plants and flowers. And really, this is, again, sort of a proportionality of how objects are seen, as an example here. And you know, the golden ratio really describes a balance between, again, the size, the proportionality, and the discovery. And we apply this now with IOL technologies, particularly here with the VSY products and the Trinova Pro, in terms of how we develop the right balance between vision, between range of vision, between side effect profiles that exist today. Now, it's interesting that despite the great interest in presbyopic correction, that the majority of correspondents still have significant concerns for multifocal lenses, specifically dysphotopsia, halos and glare, as well as contrast issues and quality of vision issues. And the survey, you can see, over just 1 year, has shown an increased utilization, for example, of extended depth of focus lenses, because these lenses purport to reduce some of the issues with multifocal lenses. There is, of course, a compromise in the range of vision, and so we are challenging ourselves that can we still address some of the issues that we see with multifocal lenses to try to address the concerns from the memberships, which are valid concerns. There's a few different important aspects that you will hear from the speakers that describe the Acriva Trinova Pro. One aspect of any multifocal lens is to have continuous range of vision for near, intermediate, and distance, and we'll show some examples of this, and we'll talk about this. Optimizing light utilization and reducing loss of light is important to retain contrast sensitivity, as well as reduce light scatter and glare and halos. And this hopefully will result in improved quality, and I think this can address some of the shortcomings as well. Let's talk a little bit about Grimaldi. Well, Grimaldi was a scientist, again, a mathematician here from Bologna, from Italy, and of course is well known for many of discoveries, including a lot of descriptions of the moon. Well, Grimaldi really described and first identified diffraction, looking at two apertures placed sequentially and showing a bending of light as light is passed to the aperture over a screen, showing a larger area of light transmission, and showing that light can bend, much like water can bend along slits. And that's basically how the term diffraction was developed and was recognized. Little did Grimaldi know that basically this principle will be responsible for presbyopic correction. Now, many of us think that diffraction is only one type of design. This example shows that many different diffractive designs that can be used to manipulate light. The most common you can see is the sawtooth design here up on the top, D2. But we're also going to show a sinusoidal design. And really, this is a unique design that's here that the Acriva Trinova Pro C uses. And there's some important differences between these designs. My message here is to remember there are different patterns. It's important for us as clinicians to help understand what the different patterns relate to the performance of the lens. Note the sharp edges with the blazed sawtooth design, the different order of wavelets that come from the waveform from these diffractive designs, and there's a significant amount of loss that occurs because of some light lost with the design. The sinusoidal design utilizes most of the light that's transmitted around these diffractive gradients with the sinusoidal design, and as you will see, this improves the modulation transfer function. This reduces the light scatter and reduces light transmission. You can see the difference here. Both can provide a broad range of vision with the diffractive designs, but 88% light utilization versus 93% light utilization is an important difference in terms of light transmission. And this, hopefully, you will see, results in improved contrast and reduces halos and glare. Now, we can change the shape of the sinusoidal design to change the distribution of energy to near, intermediate, and far as well. And this can also be changed along the circumference of the actual optic as well. So it's pretty advanced optics that allow us to also address where we want the light energy to reach. We can also then change it based on the pupil as well, because we know the pupil plays an important role in our optical function of the eye. And this can also then apply specific zonal properties for near, intermediate, and distance focus to perform the light ideal distribution. This is the defocus curve. We all look at this focus curve to show a very good near point. We see some good continuous range of vision, basically 20/20 range here or more in this important near to intermediate range, which is important for our patients, of course, as we're basically using phones and papers and screens in our lives. This is an example of the pupil design, the adaptive design, the distribution here between far, near, and intermediate. As you can see, far focus, of course, is the predominant focus. But then we see an increase in the near as the pupil gets a bit more dilated to 3 millimeters to apply and improve more near focus. Now, you may say, well, wait a minute, this design seems very interesting, but why are there no other companies doing this? Actually, many patents have been issued for sinusoidal diffractive designs by many manufacturers and strategics. There's a lot of interest in these diffractive patterns. VSY, fortunately, has been one of the leaders as a new young company to really take advantage of this design, have a commercially studied product on an excellent platform. So we're going to hear more about this. I'm going to ask Professor Auffarth to come up, who, of course, is a world expert with IOLs and designs and refractive and cataract surgery, who's done work now looking at some bench work to explain some of the theories we just discussed here. So thank you for spending some time with us. I know you're running around today, so we have you for a few minutes. Thank you.
Yeah, thank you very much for the nice introduction. Unfortunately, I don't have so good artwork. You always get the nice presentations. I have to show optical bench data, but nevertheless, I think it will be quite interesting for you as well. So these are my disclosures. I think everybody is clear that the presbyopic patient and this group of patients is a future actually also for our profession, where we have to invest quite a bit of efforts to make our business, so to say, and also to meet the demands of the patients coming to us. And you can see, because all big companies are working on these implants, there's a huge number of trifocal implants nowadays. And we really had a huge impact when the first trifocal came on the market and the whole area of intermediate vision was discovered. Before that, when I was trained, there was distance and near acuity, and there was nothing else. Nobody talked about intermediate. But nowadays, this is one of the most important features of premium lenses. And Ahmed already talked quite extensively about this, and this is quite nice that he already started talking on this. As he mentioned, there are so many different diffractive patterns, and it doesn't really matter how many rings you have. It is the configuration of the rings, it's the smoothness of the rings, it's the distance between the rings, it's the height of the rings. There's so many things coming together to compose an intraocular lens that comes out completely different. So if you just look on the slit lamp, you see, oh, these are rings. That has nothing to do with it. Yeah? So there's a lot of research being done in here to come up with the diffractive orders. Interestingly, most other companies like PanOptix or so, they're using the 0, 1st, and 2nd order for distant, intermediate, and near. But you can also extend that in this area, which the VSI lens, the Trinova, is using it, starting from here and going to the plus order. And this gives you also an advantage in terms of the light utilization and the loss of light. You've seen this defocus curve, and you will see that the intermediate area, which is very important for the patient, and if you have a lens that doesn't drop down like a peak and valley defocus curve, this gives the patient much more satisfaction and patient vision quality. So when you split off the light for the different foci, you always lose some light. And in order to minimize the loss of light, this technology has been applied so that around 7% is the maximum what you lose here, which is quite important, especially if you compare it with some of the older developments. And what he also showed to you here is the pupil perspective, how the lens works, and especially set up with the pupil diameter. And just remember this picture here. You see that with a pupil diameter of 3 to 3.5 millimeter, it increases the near. The intermediate then starts becoming better under mesopic condition. And when we look at some of the competitor lenses, the larger the pupil, the worse gets the other features. So that's a huge difference if you look at this compared, for example, to the fine vision, yeah? Or even to the Artelisa, which has a kind of balanced way, or the PanOptix, which goes up. So in the intermediate range, we really have a clear superiority here of the Acrinova. So how can we prove that? If we look at the optical bench, we use professional optical bench machinery. The optical bench looks like this. This is not a bench anymore. This is a computerized machine. And what you do is you do the measurements and you analyze the data, and we can show the data to you in different fashions. We can use different type of corneas with different asphericities, different filters, different light we apply, and then look at things that define optical quality, such as the MTF, the area under the curve of the MTF, and other things. So let's go into that. When you first look at the classical MTF curve, we have here the comparison between all the competitive lenses like the Triumph, the Artelisa, the Synergy, the PanOptix, and the Trinova Pro here. And at 3 millimeter for far, intermediate, and near, you can see here that they're very competitive, and that is, on the first look, not much difference among them. When we go further and we move up with the aperture, larger pupil, you see directly here the superiority of the Trinova, which is much better MTF compared to all the other competitors. And for far and near, it's very similar, but intermediate is much better, and you see a significant difference. When you align the MTF curve with a defocus, you also see that there's no inferiority of the Trinova Pro compared to all the other lenses. And when we go in the visual acuity simulation, which we also can do, again, you can see this flat curve, which is almost identical to what we've seen before when Ahmed described that. Now, let's go further and look at the data at different pupil sizes. And what is quite interesting is to see that a lot of these fancy lenses at 2 or 2.5 millimeter are just bifocal lenses. Yeah? They lose the intermediate part here. The larger the pupil gets, the more the intermediate part comes out by then. But with the Trinova, you see always a very good intermediate vision and very balanced. If you look at the red curve here, intermediate and near are very good. And it's always competitive for the distance, as you can see here, with the others. And when the pupil becomes larger, you can see here the Trinova getting up more and more and being the best among all these lenses. And of course, in the dark, you are not really reading something. So the intermediate vision is actually very important if it gets in low light condition. So here we compare the lenses under all the different type of pupil sizes. And we can see a very nice profile here. If you look at the Trinova, you see the balanced trifocality that you have here under the different pupil sizes. If you look at a lens like the PanOptix, you can see that this becomes almost a kind of bifocal thing with a very close interaction between intermediate and near here, depending on pupil size. And if you take the Synergy, you have very similar outcome here. So here, the intermediate range is shifted more towards another distance. With the RT Lisa, there's a pretty good similarity, as you can see here, very competitive to the RT Lisa and also to the Triumph. They look fairly similar in terms of the performance here with the through focus MTF. So, oops, go back. How can I go back? Can I go back? Yeah. So the United States Air Force target is also a thing to visualize the resolution, and you can see here from +1 to -3.5 the resolution, and you can see that you have a very competitive performance. You see here in the intermediate range, something like the PanOptix, for example, is not as good as a Trinova, also some of the others. Fairly similar is the RT Lisa or the Triumph in this area, but you can see here also quite nicely the difference with the other lenses which are on the market. So in general, we can say that the trifocal lens with this sinusoidal surface is a very interesting and an optimal optic design, has a very good light output and a better light distribution, especially in the far and intermediate range, and very strong near addition, of course. And we could really prove, so to say, some of the claims of the company, which we could really measure on the optical bench and show, especially in comparison to the others. This is a very competitive trifocal lens in this landscape here. So thank you very much for your attention.
Thank you, Professor. I know you have to run, so thanks so much for your time, and good luck getting to the big crowds. Thank you. Safe travels in the next hall. Well, you know, it's so wonderful to see the results and the optical studies that Professor Auffarth has shown. Sorry, my microphone's not working. It's so great to see the results here in the optical studies that Professor Auffarth has shown. And it really kind of helps to explain some of the theory. I love when we have the theory that translates into the optical, bench studies that I think really kind of substantiate some of the important differentiations here and the comparisons. So we have Karsten Klabe from Germany, because of course we are always interested in hearing more on the clinical side as well. How does the lens perform clinically in your clinical results? You've had experience now for, I know, a fairly long period of time, and also how it compares to some of the existing technologies out there as well. So Karsten, you're a man who wears many hats and many nice shoes, and we look forward to hearing your talk about your results.
But you have the better hairstyle, by the way.
Not today.
First of all,
thank
you for the kind invitation, for the kind introduction. And yeah, let's have a look on the clinical data. So we have seen the really impressive images from the optic bench measurement. And so I'm a simple surgeon. That's why my duty is to have a look on the clinical results. And of course, the Trinova Pro is not the only trifocal lens on the market. That's why VSI, and it's very brave, ask us to compare the Trinova Pro with the PanOptix. And we've seen already some images from the optic bench from Professor Auffarth. And so what are the main differences? Lenses at the moment looks really the same, but we have heard and we have seen that there are a lot of differences in the optical design and especially in the light transmission. And if you have a look, and that's why I've marked only two figures here, between the difference between the PanOptix, that is light transmission, it's 88% on the Acriva IQ PanOptix, and a near addition of 2.75 diopters. With the Acriva Trinova Pro, we have a light transmission, and we've seen it in the optic bench results as well, of about 93%, but makes a sense and makes a huge difference, especially on the low light condition. And we have a slightly higher near addition of 0.3, 0.6 at lens plane with the Acriva Trinova Pro. So we compared 20 patients. In 20 patients, we implanted on both eyes the Acriva Trinova Pro and compared it to 20 patients with Acriva PanOptix. These are the preoperative data, and they're really similar in age, in pre-op refraction, pre-op visual acuity. There were no difference. Here we see a really short video of the implantation. The material is a little bit different compared to the PanOptix. It opens much faster than we know it from the hydrophobic lenses. I use here the standard 2.2 millimeter Medicel shooter, and it runs easy. Usually I implant it not with the help of viscoelastic, but under BSS, and you see very controlled but fast, immediate centration. That was what I love while doing cataract surgery, so immediate result. So here we are. If we compare the centration post-op, and may you see one difference in these images, the centration on both lenses is very good. Is in the Trinova, but also in the PanOptix. But you see that this a toric lens, the PanOptix, and at the moment we don't have a toric lens from Trinova, but by the way, some secret. Next year you will get one. So, and I think especially if we talk about presbyopia correction, it's very important to offer a toric model as well. So visual acuity, here shown the data from the Trinova Pro. Monocular slightly, or binocular better than monocular because of the binocular summation, but excellent, nearly 100% 20/20 in far, intermediate, and near. And if we compare it to the data from the PanOptix, we see especially the near uncorrected binocular near visual acuity is slightly better with the Acriva Trinova Pro. Far view, intermediate view is absolutely comparable. It's the same as we've seen on the sketches from the optic bench. But okay, that means, okay, that what Professor Auffarth told us, we can say, yes, it's true, and it works as well in real patients. So, and then there are some other aspects we have to talk about if we compare presbyopia correcting lenses. That is the defocus curve, as Professor Auffarth told us, and contrast sensitivity, as heard before. So what we've done, especially in contrast sensitivity, we checked it under photopic and mesopic conditions at 1 meter. So I lost my image, here we are. And the red graph is from the Trinova Pro, and the blue one is from the PanOptix. And here you see the difference between both of the lenses, and that is because of the better light transmission. It is not as good in mesopic condition as we see in a 20-year-old healthy eye. But there is a significant difference in the contrast sensitivity, especially under mesopic condition, and that is an add-on patients love to have. So here we see the point spread function at 3 and 4 millimeter aperture, which underlying the different or a little bit different design. Far view is clear, as on models the same, but in the intermediate and near view, there is a slight difference between the PanOptix and the Trinova Pro. So we've seen these curves before. That is a binocular defocus curve, theoretically derived. Here we've seen the Trinova curve we've measured on the optic bank, and that is the gray one, that is Ike's eye. Yeah, so for 20/20, intermediate 20/20, and near 20/20. The green one is mine for 20/20, and then it goes down immediately. No, but I'm joking. The blue one is the PanOptix, the Trinova is the red one, and we see comparable in far view and intermediate, but a slightly better near view with the Trinova Pro, and that is what we see, what patients love to have, that they probably, and look at him, he is working on the iPhone. This distance, I can't see anything. So, but with a Trinova, I could. So, and next halo and glare. And we see images from the optic bench as well. And the difference is really not to be seen between the Trinova and the PanOptix at 3 millimeter and 4.5. Slightly seems to be a little bit larger with the Trinova Pro. But if you ask the patients, they are really, really satisfied with this lens. The vast majority got the impression is very good, and they perceived halos, yes, of course, because of the optic design. But most of them tell us, okay, they are not disturbing, not at all. So, and we compared it with our healthy young stuff, 68 eyes, mean age 26, half the age of me, and they had more halos and glare than we've seen with the multifocal lenses. And the results of the Acriva Trinova Pro and the Acrisoft IQ are in these really small group, and keep in mind we only compared 20 patients. And the results were after 3 months, and it's absolutely comparable. It's the same. Both lenses work well, and both lenses, and that was surprisingly for me, work better than the natural lens in a human eye. So thank you very much for your attention.
Thanks, Karsten. We'll take some questions maybe after our next talk with Ramon, but I still don't see you wearing glasses most of the time, so you're still doing pretty well. Are you sure you haven't had surgery yet with the Acriva Trinova Pro? It looks like you have.
Yeah, I have.
Well, thank you very much for sharing those results. I think it's really interesting, again, looking at comparative results, because over the last, 15 plus years, we've seen continual improvements in presbyopic IOL technologies, and each one kind of builds on the next one above and forward, and we continue to see this progression of improvements, and I think we need to always look and see where we compare to some of our market leaders. So it's great to see that, and I do want to also make sure that there's an opportunity for any questions that some of you may have. We have microphones in the room. Feel free to use those. We have a discussion period coming up afterwards as well, so feel free to do that as well. But I do want to introduce as well and continue to speak about clinical results, because I know that this is still a lens that probably many of you have not had experience with. By the way, just by a poll, I'm curious, how many here are using presbyopic IOL technologies for their patients? Okay, great. And how many have had experience with the Trinova Pro C? So you have some as well. Okay. Okay, great. So I think we have a pretty good mixed audience. So we have Ramon here from Spain, who will also speak about his clinical results and his perspectives on the lens.
Okay, thanks, Ike. First of all, thanks to BSY team for the kind invitation to participate in this event. I am going to talk about my initial clinical outcomes with a new synovial diffractive trifocal IOL. And now, the laser refractive surgery and less commonly intraocular lenses are used to correct the refractive error, but if we are talking about the presbyopia restoration, of course, we are focused on our practice in the multifocal lenses. So, my previous speaker has said before, the golden rating enhanced synovial trifocal we have find in the new Acriva trifocal lens. They look for no more compromise, discover the colors of the light with the maximum light transmission in the retina, no thing claim for the patient about this phototoxic phenomena, and to offer an optical excellence. Differential lens, diffractive design in general is a thin refractive lens constructed by removing the non-refractive parts of the lens and reduce the amount of material required compared to a conventional lens by dividing the lens into a set of concentric annular sections. So the overlapping pattern that we have, the diffractive lens have to use in order to achieve a third point, third focus, reduce significantly the light transmission, even losing transmission of 15%, and for this we are going to find more glare and halos. This is the difference between this Trinova Pro C pupil adaptive IOL with the different more common in the market trifocal lenses like Five Vision Official, Itilisa for Zeiss, or PanOptix for Alcom. So it's important what benefit we are going to find. As I have said before, sorry, the presentation? Okay, thank you. Perfect, thank you. There is an overlapping between two focus, so we are going to enhance the light utilization, and one ring in both of three different focuses follow us to achieve less glare and halos, and for this more efficiency. So this lens try to offer a continued vision at all the distances without any type of peaks between different distances. This is the focal curve of the lens that has shown before for the rest of the speaker. Many important, not compromising the visual quality for this type of lenses. In my short experience, we don't have found any patient with high claims about the photic phenomena like halos or glare. This is the most important thing. This lens the behavior of this lens like a natural crystalline lens. So we have received 90% of the light to the retina when our natural clear lens show us 95. An important feature of the lens is the pupil adapted energy distribution, as the Dr. Auffarth and the previous speaker has shown. This lens seems to adapt for the different diametric of the pupil size. The balanced light distribution, as explained before. So this is a GROA with a very, very good performance every type of distances, near, intermediate, and far. And this that the technical feature for all the audience that are not used still with this type of lens. This is the difference, how this company has improved the feature of the lens if we compare with the predecessor. I result 93, even with more light transmission. A little bit more addition for distant, for near and intermediate vision, is pupil adaptive, and of course the change to the optic, to the C-loop. I think that's better for all type of white to white measure in every patient. This is my short experience, only 5 bilateral patients, 1 male and 4 female, with different IOL power from 16 to 25.5. with only 2-3 months of follow-up. This is the result of our distant, intermediate, and near vision of this short group, and corrected vision from every type of distances, and with correction of that. The focus curve show very good result, and I want to underline again that we are not find any type of peaks between the different distances. This is our result. The contact sensitivity with very good contact sensitivity, very good performance in all frequencies, even in all frequencies. No patient show photic phenomena of 3 months. Even after the good experience with our first patient, we implanted this type of lens in a patient previously with LASIK myopic surgery. After review all the spherical aberration with very good values, we performed this style of surgery with the type of lenses, and we have found very good result. To conclude, I think that, of course, it's too soon to talk about conclusion, but we can do it about impression, very good result, both quantitatively and qualitatively. Good performance in different patient profiles, depending on the age, different age and refraction, even in the case of post-myopic LASIK. Of course, we need more time as experience to contrast this first favorable impression. Thank you so much for your attention.
Yeah, I always forget to turn the mic on. Well, thank you very much for the presentations. I know that Professor Auffarth had to leave, but we're happy to take some questions with regards to his presentation. We have actually some good time for interaction. Sometimes the courses are so tight, there's no time for discussion. So we're going to put everyone to the test. And so it's good to get Lisa to start off. It looks like she's ready to go at the mic. But we do want to encourage discussion. Ask anything you want about IOL technologies or presbyopic treatment, or specifically about the Trinova Pro C lens, or about diffractive principles. We'll see who wants to tackle that one. But please, okay, Lisa, go ahead. Thanks. Nice to see you.
Hi, you too. Thank you for the wonderful presentations, and I'm very interested in the fact that we're creeping closer to ideal acuity. Are we close enough, Ike, that you would use this for your glaucoma patients? Question number 1.
So I think, I mean, the glaucoma patient, of course, is such a wide-ranging patient, So I think, I would say this, let me give you one example. Someone who's got very severe disease, I don't want to have any compromise of vision or any risk. That patient, I'm not going to take that chance. Patient who's ocular hypertensive, mild disease, I'm much willing to take, and I have done multifocal lenses in those patients who are stable. I think they have minimal contrast loss, and I want to use the lens that, of course, is going to provide the greatest amount of transmission, which so far on the market, this lens does. Of course, we've now entered the era of EDOF lenses, and we're all interested in that as a category, but it's all about, again, customizing for the patient. The difficult questions are more the middle patients, right? The ones that are kind of mild to moderate, they got a visual field defect, that's, not too small. Is that one going to progress or not? Those I find more difficult, and I think I have to really talk to the patient and see how motivated they are. The age plays a role. A younger patient who has a significant defect has a risk of getting worse in the next 10 years. I may be more concerned about. So, but yeah, like you said, we're inching inching closer to that. Certainly my utilization of presbyopic lenses is increased over the last 10 years in glaucoma patients for that reason. I think this continues to up the ante. So that's my long answer, politically correct.
My other question is regarding EDOFs. Were these all best corrected, enhanced eyes with perfect correction? And is there any wiggle room as far as, ability to be a little off of perfect outcome refractively as there is with EDOF?
Okay, so yeah, I mean, that's an interesting question about refractive targeting. I think you're saying, Lisa, for EDOF lenses, we often aim a little bit of myopia in one eye or non-dominant eye to give a bit of that, I don't want to call it monovision, but that increased range near.
But yes, but more than that, I think at least the impression is that the EDOF lenses are a little more forgiving of a not perfect target outcome
okay, let's talk about that.
Does this have any wiggle room like the EDOF, or is it closer to a standard diffractive lens, which really needs to be on target?
Yeah, okay, great question. I'm going to come to Karsten in a minute, but let me just clarify here. So we're talking about, not just the accuracy, but the landing zone in terms of hitting that mark. And this really has to do with the defocus curve. When you see how much of that defocus curve is in that, distance focus, a lens that you can be a bit off on your refraction, but still 20/20 means that you have a good target, a good landing zone to hit that mark. And as we've heard, of course, multifocal lenses, they often have a very narrow landing zone, right? The peak of that defocus curve is pretty small, and you have to really hit that mark well, because you have to, any kind of refractive error can result in loss of function. EDOF lenses, some of them do have a larger landing zone. There's a bit more flexibility. If we're off a little bit in the refractive target, then we can still retain good vision, because that landing target is more flat as we get to that defocus curve. So what has been your thoughts, experience, in terms of this particular lens, the Trinova Pro C?
So first of all, two excellent questions, and I won't
answer
the second one first, of course. So an EDOF means a blurred vision in every distance. So I'm joking. But you are absolutely right. There is a wider landing zone, and with the Trinova Pro, you will have a happy patient if you address it strict emmetropia, and then it works perfect. So that is because of the diffractive design. So and that is, in my opinion, for all diffractive lenses. May I can go back to your first question, which, in my opinion, is not because of we have Ike here in the podium. Very important, because I have a large number of glaucoma patients asking for presbyopic solution. And so nobody knows exactly. We started to measure it with EDOF and with trifocal, not with the actual Trinova Pro, but we didn't see any difference between glaucoma patients, and we've measured it in 3 subgroups on the severity of the glaucoma: mild, moderate, severe. Okay, it doesn't make any sense to put a trifocal and a severe visual field loss, and with a loss of contrast sensitivity. I think the major issue is contrast sensitivity. But these lenses work well in patients with mild and moderate glaucoma as well. So it's not the perfect solution, especially in moderate, and have a look on the contrast sensitivity the patient offers before surgery. and have a look especially on the visual field, not only on the MD, but on the location of the difference. But it's, in my opinion, it's my personal opinion, it's not a mistake to offer these patients a presbyopic correction.
Okay.
Please, Ramon.
Yes, I think that the first of all, you have to optimize, of course, the A constant. Once you are sure that the A constant is the ideal, for some EDOF lenses, it's true that we can play with the micromonovision and to want to look for the first myopic shift. In some of EDOF lenses, even the first hyperopic offers us better performance of the lens. But in this type of lens, trifocal lens, and for me, in any type of trifocal lens, I agree with him. Sorry, I choose the emmetropic shift, close to 0.
So, you know, I mean, I know Lisa, she always asks really good questions, so thank you for that. I think, you know, in the end of the day, it's going to be clinical results, but then we also have some good bench results to look at that. And I think when you look at the differences between like a blazed, you know, sawtooth design, the sinusoidal diffractive designs, according to my experts at the company at least, tell me that they're more tolerant for some refractive error, you know, just by this design, you know, without the sharp edges on the diffractive ring. So theoretically, there seems to be some, you know, benefit as far as having a bigger landing zone for that refractive target. And I think there'll be some bench studies being published on this question that'll come out soon to discuss that point. So that'll be interesting. You're absolutely right, because we can never hit the exact target, although we heard we have to do everything we can to get there. And we may ask that question later on about what do we do for that. So I think that there's some theory behind it. Maybe there is a bit more tolerance. We'll see. We'll see with that. Good question. Please, let's get the mic. We have some good time. This is your time to ask. You go to how many meetings you go to, and there's no time for questions. We got time for questions here. It's great.
Hi,
Please.
I'm Barbara Parolini from Italy.
How are you?
I'm fine,
Nice to
thank
see you.
I'm mainly a vitreoretinal surgeon, but I do cataract as well.
And you're a very good one,
a lot of
too.
IOL. Thanks. So actually, to back up the combined conditions, I can tell that even in patients with retina problems, I don't think it's a major contraindication to use premium IOL, as of course depends on the severity of the problem on the retina, but as long as they can wear a multifocal spectacles, they can also wear a multifocal lens, even with actually better results. And my question to you is, what about toric choice? So what is your threshold to choose a toric IOL based on the astigmatism? It's going down and down. With the improvement of the design of the IOL, we go down and down, and maybe now it's 0.75, but I would like to know your experience, your choice.
Okay, good question here. So first of all, I would never argue with the vitreoretinal surgeon about those issues. So I'm glad to hear that you have some of those considerations. Like glaucoma and ocular surface and cornea, we're always careful, you know. And so, but people are expanding the technologies. The technology gets better potentially with maybe some traditionally relative contraindications. So that'll be interesting to hear some of your results as well. So yeah, let's get this question here just about, you know, astigmatism management. You know, what is your threshold? What are your targets? How important is it?
But first of all, may I can get back to the vitreoretinal. So Karsten Klabe joined us last year, my vitreoretinal colleague. So, and he measured the EDOF and trifocal lenses on a simulator on patients with macular pucker and AMD. And the same results. Multifocal works the same way, and EDOF works the same way as in patients without. It depends on the severity of the disease. Sometimes it's more challenging to do a surgery, to do a peeling, if there is a multifocal lens is implanted, but they work under this condition as well. So, but of course, it always depends on the severity of the maculopathy. The second, my limit, it depends on the surgically induced astigmatism. I know, so I usually do the main incision at the stepper axis, and that differs a little bit at the 12 o'clock position. My induced astigmatism is about 0.5 to 0.7. Temporally, it's 0.5, and all astigmatism above 0.75, I tried to implant a toric lens. It goes down.
Okay, I think that regarding the astigmatism question, it's different if we are going to work with monofocal lens. In this case, even I can maintain one diopter of astigmatism if it's against the rule, because in the non-dominant eye could improve the near vision. But we are working with trifocal, even with EDOF lenses. Minimum 0.75 is necessary to correct in order to decrease the quality and the quantity of the vision after the surgery.
Yeah, I think the tolerance for me continues to go down and down. I mean, you know, it does depend on the patient. Some patients are content with 0.75, but I really try to get down as, you know, to 0.5 or less for these patients. I just think that they have just, you know, better improved, you know, quality. I run, you know, my toric calculators, and I usually don't have a threshold for where I treat astigmatism. I look to see what the projected residual astigmatism will be. I use the Barrett calculator, and I look at the residual astigmatism, what it's predicted to be, and based on that, I decide whether to correct the astigmatism with toric lenses or with a corneal treatment. So, you know, because it will depend, of course, what the axis of the astigmatism is and the given patient. So I run the calculator on everybody, every patient, even if I think they don't need a toric lens, and I look at the residual amount, and if it's going to show it's going to be, you know, 0.5 or more, then I'll use, you know, a toric lens. And even if it's a low-power toric, I'll use it with a presbyopic lens. So I think astigmatism is important to treat. Of course, I can treat it after surgery too, but it's nice to treat it at the time.
Yeah, that's true. We are always fear, you know, dislocation of the lens in time that could change the results significantly. So I'm always concerned about whether it's better to choose a spheric and then correct the astigmatism, or choose the toric. And of course, we want to reach the best result with one procedure. So.
Yeah, and I mean, I don't, people are different. My opinion is that astigmatism is so much more stable treating on the lens than on the cornea, certainly with astigmatism treatment, you know. But of course, it's good to have different options. Thank you.
Thank you very much for your very nice talks. You said more or less light transmission a little bit more than the other lenses, 93, something like that. It affects or it influences to the contrast sensitivity. This is the first. And do you offer multifocals to diabetic patients without retinopathy?
Okay, so two questions. One question was regarding, I think it was regarding contrast sensitivity, the testing, and the second question was using in diabetes. So
yeah, there was no significant difference under photopic conditions, but we've measured a significant difference under mesopic conditions. With the Trinova Pro works better, and in my opinion, due to the better light transmission. Yes.
Okay, good to know.
And the second question is diabetic retinopathy, also a patient without diabetic retinopathy, but a diabetic patient. Yeah, so it always depends. Yeah, but I would offer them, as I see the history of the disease, so long time. If the patient is in my office over years and I don't see any change, and I know the blood sugar is well controlled, I would offer this. Yes.
I have two practical questions. Two of my patients, I mean, so I have given a trifocal toric, and the patient when set in the autoref, it was showing that still he has some astigmatism. So all the, lens placement and everything was accurate. What to do in this case? And the patient was having a quite relative good visual outcome. And the second question is that if give a trifocal lens and the patient complains of glare, halo, you know, whether to go forward for the same lens on the other eye. And I am Dr. Ishtiaq from Bangladesh.
Nice to see you. Good questions. Okay. Let's tackle the first question. Carsten
Really,
will say it depends.
no, so really tough
depends.
questions,
It
by the
depends.
way. So, and that's why you sent it to us.
Yes,
Yeah,
exactly.
okay. Thank you for that.
I can
No,
answer
so
them too.
by remaining astigmatism after surgery, so first of all, yeah, check the placement. In most of my cases, I see a slight rotation, and probably so. Also with the help of the IntelliAxis system we use on the lenser, sometimes there is not only a rotation but a mismanagement in the preoperative assessment. So first check these, and then we have some options with, I wouldn't place another lens, another toric lens, but I would go for a corneal procedure to correct these astigmatism. The second one, halo and glare, okay, I try to avoid to implant it to patients which are too pushy. So, and that is I think the preoperative impression of the patient that is not only measuring, but if there is a severe dry eye and the patient is not disturbed about anything with the cataract, so then you can put in a trifocal. It doesn't matter on anything. So, if there are halo and glare, so first of all, I would discuss with him to replace the lens before I put another lens in the other eye.
Yeah, I agree. I mean, if they have severe glare and halos in the first eye, I don't like to do the second eye. They're going to be upset. Why did you do my second eye? So I try to wait. I try to suggest that they can wait over time, to adapt to the halos and glare, see if it gets better. Often it does get better, and then see how they feel. So that's my general feeling. I don't like to do an IOL exchange or explantation until at least 3 months or so to give patients time to do that adaptation. At that point, though, I think it's important to proceed to do something. So patients are unhappy if they're complaining very badly, and you wait for 6 months, a year. It can be done. I take lenses out of eyes 5 years later sometime, or longer. But to the patient, they get more frustrated if there's not much happening, if they need to do that. So I usually like to make a decision at 3 months. If they have ocular surface disease or whatever, we're treating all these things to treat that as well. But I try to sort of wait for that time period. But I don't do a second eye. Now, if it's an issue of visual performance, like, doctor, I want to see, I'm not reading as well. That may be a function of binocular fusion and summation. So in that case, I think it is good to do second eye and say, listen, when you get both eyes done, there's a better, summation of the images, and you're probably going to get better with regards to your near vision, for example. So I try to encourage second eye if that's the issue. So it depends what the issue is on that, But I know one question that we do get from people is, we talk about neuroadaptation. And maybe, I don't know, Ramon, what you think, or Karsten, but what do you define as neuroadaptation? And for these lenses, how long does that take to develop for patients on average, or the range of that developing?
Every patient is every patient, of course, and you can find different results with the same lens depending on the patient. I agree with my colleagues. We have to study and to avoid the preoperative complication in order to avoid to implant multifocal lenses in not suitable patients for this. In the case that we have some claims about halos, glare after the surgery, I have to, first of all, review all the surgery. If there is some problem regarding the capsular resid, the centration of the lens, I wait for 3, 4, 5, 6 months. And in the case that patient continue with the claims, I have to offer the option to change the lens for another one.
Yeah, between 3 to 6 months in my, say.
Yeah, one thing that's important is counseling, and I show every patient a picture of halos and glare. Any kind of diffractive technology, whether it's EDOF or whether it's a full range, I think it's important to show a picture of that. And patients understand this, they appreciate showing a picture, and they can see then, what to expect. And if the patient's first reaction is like, then for me, then they're not a good candidate for that, But I like to show them. The second thing is I talk about adaptation. I say, listen, we're giving you a whole set of new optics in your eyes, like a new lens in your eye, like a camera. This takes time to adapt. So I'd like you to, to just, just trying to work with me, give it a few months, and be prepared for it. I think preparing and expectations are so important for patients, because we expect something, but if we don't have that conversation with our patients, then they're unknown. They expect things to be right away, and they may be unhappy. And it's all about that patient-doctor relationship, and strengthening that relationship, which starts before surgery. So I think all the aspects of success after surgery are so much related to before surgery: biometry, counseling, patient selection. All these things are so important to the secrets. And every so often, yes, if we do get a patient that slips through the cracks, but by doing all these things, I think we can do the best for our patients and choose the right technologies. So I want to thank our panel members for the discussion, and thank you for asking questions. Before we finish, though, I want to just share a couple of slides. VSY is a company that is really kind of giving back to the community, and over the number of years, they've been holding this competition called the Ophthalmology Star Awards, and there's many submissions from across the world that submit, abstracts and research into various areas of ophthalmology, and there's a committee that basically selects, some of the best papers that were submitted, and there's an award. I think there's no attendees here that was able to attend the session, but I want to just show you here. Dr. Leonardo has a publication on COVID-19 that was awarded the 3rd place prize. Dr. Nazrul Islam here, looking at OCT and retina and looking at multi-level deep feature generation framework. I don't know why there's so much retina stuff going on here, but and then there's a tie for the 1st place award, which is cataract surgery and AMD, and also a novel, just yet another IOL power calculation formula, the O formula. So congratulations to the award winners. Thank you, VSY, for supporting this initiative. And those of you who are interested in who are doing research, please pay close attention to the next round of awards that will come up in 2023. There is a session coming up very soon with Oliver Findel and Dr. Bazak and Dr. Florian here with regards to debating hydrophilics and hydrophobics. It'll be a good debate about material technologies. So please visit, and thank you, VSY, for being a great partner in developing technologies and great people to work with. I encourage you to visit and talk and learn more about these technologies.